look okay?
That's perfect. Thank you so much. And welcome back to our 11th session of the Iowa Maternal Health Echo Series, which is crazy to say out loud. But again, thank you all for being here. I'm excited to talk about our subject matter experts here today, bringing a wealth of knowledge relating to abortion care and obstetrical emergencies and relating to the documentation provided for those medical services. Starting in no particular order, I have our Dr. Nisha Verma, who is the current Senior Medical Director in Clinical Affairs at the American College of Obstetricians and Gynecologists. Dr. Verma completed her residency in obstetrics and gynecology at Beth Israel Deaconess Medical Center, followed by her complex family planning fellowship at Emory University. She also received her master's in public health degree. As adjunct assistant professor at Emory, she leads community-based research on the impacts of Georgia's 6-week abortion ban, which is very similar to Iowa, which is why we're very excited to have you here today, in order to mentor trainees and to provide clinical care in Georgia. In addition, she provides clinical care in Massachusetts and serves as an instructor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. At ACOG, Dr. Verma spearheads efforts to create legislative, institutional, and policy environments that support implementation of evidence-based guidance. And Dr. Verma also serves as a national spokesperson for reproductive health-related issues, including access to abortion care, and has testified in front of Congress multiple times on the harms of abortion restrictions. We also have Dr. Rachel Jensen joining us today, and she is an OBGYN and subspecialist in complex family planning. She earned both her bachelor's degree in psychology and her medical degree from Northwestern University in Chicago. She completed her residency in obstetrics and gynecology at the University of Maryland in Baltimore, followed by a fellowship training in complex family planning at the University of North Carolina, during which she served as ACOG District 4 Junior Fellow Legislative Chair and American Medical Association representative. And last but certainly not least, we have Alyssa Morrison, who is the Senior Staff Attorney for Reproductive Justice at Lawyers for Good Government, which is a fantastic name, by the way, where she serves as the in-house legal expert on both federal and state reproductive rights policy. She oversees the reproductive rights and justice portfolio, including policy, advocacy, education, and litigation-related projects. And prior to joining, Alyssa spent 5 years working in federal civil rights litigation in district and appellate courts across the country. Alyssa received her JD from SMU Denman School of Law and obtained a BA in International Studies from Texas A&M University, and she is licensed to practice law in Texas. So we're very grateful for you to be here today. That's all that I have. I'm going to hand it over to our experts to get us started. Thank you.
Thank you. Thank you for that introduction and to all of you for taking the time to be here with us. So today we're going to be talking about understanding care provision and documentation under Iowa's abortion restrictions. So we're going to start by just introducing our organizations that we work with, the American College of OBGYNs and Lawyers for Good Government. And then we'll talk a little bit about a project that we have been collaborating on between ACOG and L4GG to support folks in states with abortion bans and restrictions in navigating those laws and being able to provide as much care as they can under the laws, and figuring out how they can document safely to protect themselves and their institutions. And then that'll be kind of the didactic part. Feel free to jump in with questions as well, and we'll answer those as we go. Christina, I may not always see with like my screen up, I might not see the question, so also feel free to like come off mute and interrupt me. And then we will turn off the recording and go into some cases to think through how to put these principles in practice in what you all are dealing with at your institutions. So the project that we're going to be talking about today is a collaboration between ACOG Foundation, and I have a little bit of information about ACOG Foundation here. So this is the philanthropic arm of the American College of OBGYNs, which is an organization that represents over 62,000 members across the United States. And the foundation component of ACOG is really focused on supporting the charitable, educational, and scientific programs and activities of ACOG. So we do a variety of community-based interventions, patient-facing education materials, trainings, and the project that we'll talk about today is part of the work that we do with the ACOG Foundation. I'll pass it over to Alyssa to just introduce Lawyers for Good Government.
Yes, hi everyone. Thank you so much for having me, and I'll be super quick on this slide. So L4GG, we are a legal nonprofit, and we work to mobilize lawyers, legal professionals, as well as our broader community to ensure that all levels of government promote equal justice under the law and uphold civil and human rights. So we have a community of around 125,000 pro bono lawyers, as well as our in-house staff of around, I guess, just over 50 now. That work in tandem to um, to build out our projects and kind of amplify their impact. And then our focus areas are climate change and environmental justice, immigrants' rights, which is our Project Core Zone team, and then civil rights and health equity, including reproductive rights and justice, which is the team that I work under. You can go to the next slide.
So we as ACOG and L4GG came together post Dobbs as we saw abortion bans and gestational age limits go into effect around the country to figure out how we can support clinicians practicing in these states, trying to navigate OB emergencies, OB complications, take care of people coming into the hospital, and how we can help their hospitals support clinicians better in this work. So you see on this map after the Dobbs decision, multiple states put abortion bans and gestational age limits into effect. As you all are aware, Iowa had a law go into effect that bans most abortions after about 6 weeks from the last menstrual period. Alyssa in a couple slides will go like more specifically into the law and kind of the specifics of it, but this is kind of the landscape of what we saw post Dobbs. And we saw that people have not been getting needed health care, including in obstetrical emergencies. In this landscape post Dobbs, we saw that many clinicians are facing moral injury. We're having to turn away patients that needed care. And we also saw that institutional policies and support really do matter when it comes to maximizing care under these laws. So we were hearing huge amounts of variation from clinicians practicing in even just one state, in Georgia or in Iowa, in terms of what care they were able to provide under the law, based on the level of institutional support and hospital policies and protocols that existed. And we were having a lot of folks come to us and ask for support in helping their hospitals develop those policies and protocols to allow them to navigate care under the law and provide care for patients under the exceptions to the laws. And so that's where we stepped in to really support hospitals in thinking through how they can develop safe protocols and policies and guidance for their clinicians and doctors that allow us to provide as much care as we can to our patients under these laws while also having the hospitals and clinicians feel protected. So this program was really inspired by the stories that we were hearing from clinicians, from patients, requests from hospitals, from doctors, and research findings of like what was needed in this environment. And so this is the program that we have put together. It is called Respond. So the reproductive care expansion and support through protocols, organizational policy, and network development. I know it's a mouthful. We came up with the catchy kind of like one word respond first and then tried to like make the acronym fit. But so this is our program. And again, the goal is to really support hospitals who are facing this environment of uncertainty, confusion, post-Dobbs, trying to navigate abortion bans and restrictions like what you all are facing in Iowa. And so as part of this program, we actually developed state-specific sample hospital protocols that help folks maximize reproductive care under restrictive laws. We piloted this program in Georgia, which is where I practice, and then we expanded to Iowa as well as Oklahoma, and are now starting work in Texas and have a list of additional states that we plan to expand into. But we do have an Iowa protocol that we can also share with all of you all. I can share it with Christina and get that out to folks if that's something that's useful to you all. We also have an email address that you can see here, respond@acog.org, that you can reach out to with questions. In addition to providing those protocols, our team actually provides no-cost consultation to help with implementation support. So thinking through how to get these protocols implemented at your institution, how to think about getting staff buy-in, how to think about what case, like approaching certain cases, thinking through how to, and we'll go through cases together here, but we actually do case-based presentations for institutions. We bring institutions within a state together for convenings where they have a space to kind of talk through what is and isn't working, and learn from one another. So those are all things that we can offer as part of this program. And again, this is something that we are doing in Iowa. And so we're also excited to kind of do this presentation to connect with you all who are at your institutions doing the hard work and figure out how we can continue to support you all. This is just kind of like a brief screenshot of the very beginning of the protocol, but it's a multi-page protocol that, again, we can send out to you all. It goes through, kind of the way that we've set it up is we go through the law, the specifics of the law, but then actually list out like how to approach a patient coming in, for example, that might meet the medical emergency or medically futile pregnancy or rape incest exception, how to figure out if someone is eligible, how to proceed from there, documentation requirements. We also have sample EHR language in the protocol that we will go over with you all today as part of this presentation as well. So with that, Alyssa, I'll pass it over to you to just give an overview of the law itself.
Mhm.
Again, we have some of this information in the protocol, and then we'll go into some of the considerations for documentation.
Yes, thank you so much, Nisha. So, and I'll be pretty quick about this. I just want to walk through it to kind of level set so that we all have top of mind what the law actually says and requires before handing it back to go through the case examples. So I know you all are probably familiar, but bear with me. So Iowa in 2024 passed its roughly 6 week abortion ban. And excuse me, I'm on the mend from bronchitis, so a little iffy. But it prohibits abortion after there's a detectable human heartbeat, which it defines as cardiac activity, the steady and repetitive rhythmic contraction of the fetal heart within the gestational sac. There are certain exclusions from the law, and these are distinct from the exceptions, which we'll talk about in a second. So exclusions are just not considered abortion under the law. So Iowa law excludes the removal of an intrauterine fetal demise from its definition of abortion. Importantly, it does not explicitly exclude ectopic pregnancy, which a lot of states with similar laws do. But we'll talk about that in a second and how it should be treated under the exception for medical emergency. So the exceptions fall into kind of four broad buckets. You have your medical emergencies, your fetal abnormality incompatible with life, rape or incest exceptions, and spontaneous abortion or miscarriage. Next slide, please. There we go. And I just want to, I know it's a lot of text on the screen, but just so you have it, just the elements of each exception because they each have their own requirements. So for the medical emergency exception specifically, it requires a physician's reasonable medical judgment that the abortion is necessary to preserve the life of the patient, or that the continuation of the pregnancy will create a serious risk of substantial and irreversible impairment of a major bodily function. And then the law defines what is considered a major bodily function. Importantly, that does include reproductive functions for things like ectopic pregnancies. Psychological conditions, emotional conditions, familial conditions, or the patient's age alone do not qualify a patient for termination under this exception. So, for example, if you have a patient, who is experiencing a severe mental health crisis aggravated by pregnancy, that alone, absent a physical emergency, is not going to qualify for the exception. Next slide, please. So for the fetal abnormality exception, and again, I know I'm going pretty fast and just super high level here, but so you have a gestational requirement, and then you have the elements for what falls under the exception. So in this case, you need a probable post-fertilization age of 20 weeks or less, an EJ of 22 weeks or less. The laws use different phrasing throughout. And then the attending physician certifies, once again, it's that reasonable medical judgment standard that the fetus has a fetal abnormality incompatible with a life. The law does not specify which conditions qualify, nor does it particularly define what in fetal abnormality incompatible with life actually means. Once again, leaving it to the physician's reasonable medical judgment, but there has been some guidance from the Board of Medicine. So the Board of Medicine has set out documentation and certification requirements and stated that the diagnosis and the conclusion have to be reached in good faith following a bona fide effort consistent with standard medical practice and reasonable medical judgment. Next slide, please. So for the rape or incest exceptions, once again, you have the gestational age limits as well as the other elements. So in this case, it's again that 20 weeks or less post-fertilization. In the case of rape, it has to be reported within 45 days of the incident to a law enforcement agency or to a public or private health agency, which can include a family physician. And I do want to underscore that because some state laws that are similar have an explicit requirement of a police report, and Iowa's law does not require that. It just requires reporting to law enforcement or to the healthcare provider. And in the case of incest, the reporting requirement is within 140 days and has that same those same conditions for reporting. Next slide, please. And then finally, Iowa has the way that the legislature has written it is somewhat wonky. They have an exception for miscarriage, and I want to remind y'all at the top of this that removal of an IUFD is not considered an abortion at all. So in this case, we are talking about an active miscarriage, and you'll have to forgive me if I don't explain it clinically properly, not a doctor. But so in this case, once again, you have the probable post-fertilization age of 20 weeks or less, and a spontaneous abortion, commonly known as a miscarriage, if not all of the products of conception are expelled. So this statute, it should allow for the intervention, including abortion care in the case of a miscarriage that's in process, where fetal cardiac activity may still be present prior to 20 weeks. And it's written in such a way that it appears that the exception only applies prior to 20 weeks, but it does not. But once again, Iowa does not include the removal of a dead fetus in its definition of abortion at any gestational age. So in this case, prior to that 20-week mark, even where there is fetal cardiac activity, if it's a miscarriage in process, you should be able to intervene to provide standard care. And I believe that's the end of my slides. Okay, thank you for bearing with me. I know that was all fairly dense and somewhat boring, but I will pass it back.
It's helpful to, and Alyssa, I was going to pull up, before I go into documentation, I'm going to pull up the protocol itself just to
Yeah,
show folks what that looks like. But do you
yeah,
want to speak just briefly about the topic stuff too that you mentioned, how it's not the medical, like it's not specifically listed, uh,
yeah.
but can be done while I pull that up?
Yeah, absolutely. And we have that set forth in pretty significant detail within the protocol. So most state laws that look similar to Iowa's, or most state laws that are total gestational bans, like I'm based in Texas, we have a total gestational ban, specifically carve out ectopic as an exception to the law. Iowa's does not. However, under the medical emergency exception, you have that language around substantial impairment of a major bodily function, which includes the reproductive system. There are, once again, I am not a clinician, but from my understanding, no scenarios in which an ectopic pregnancy does not pose a serious risk to the patient, and so those should be treated under the medical emergency exception. And also just flag, like from a legal perspective, there have been no cases, certainly in Iowa, and as far as I'm aware, nationwide, and I'm pretty sure that I'm right on that, that have involved investigation or certainly not prosecution, but even investigation into a provider for treating an ectopic pregnancy consistent with care.
Perfect. Thank you, Alyssa.
Mhm.
And I was going to just briefly show, I'm going to go into some documentation that we're pulling from the protocol and how to think about documentation, but I also wanted to just pull up the protocol for you all to see like what this looks like. And again, this is something we can send out to you all as well. So I'm just sharing this here. So this is kind of what the protocol looks like. We have these that are state specific for the states that we're working on. So we do have like the sample watermark because hospitals can take this and make it their own. We have kind of this one pager that just sets the stage. I think part of what we have also been clear about with this work is doing this work of helping folks navigate these laws is not an endorsement of the laws in any way, but is really harm reduction, right? We have to figure out how to provide care for people in emergencies, experiencing complications, in the settings that they're in, and the harm reduction component is really important. And so we go through a lot of what Alyssa just went through, like the definitions, medical emergency, how the law defines it, the exceptions, and then have like a procedure for determining patient eligibility, determining if fetal cardiac activity is present, how that affects eligibility, going into like, for example, IUFD, ectopic pregnancy, and we do detail this as Alyssa was saying, the nuances of the Iowa law, and then medical emergency, how to approach that. And then we actually specifically added the pieces that I'm going to go over now around, and then before I get into this, so then we have like the process for eligible patients, so patient education, informed consent. But then this last part with documentation, we added as a direct kind of response to requests that we were getting from hospitals and clinicians who wanted more guidance on the documentation pieces. And so we also added this piece here on documentation as well as some suggested EHR language for patient charts. So just wanted to like pull that up so you kind of have a sense of what that looks like. And then I'm going to go back to sharing the presentation itself, and we'll talk through some documentation approaches, and then we'll stop, answer questions, and go through cases. So I'm going to pull this up again, and current slide. Oops, hold on 1 second. Resharing here. And then as I pull this up too, one thing I'll mention, another piece with these protocols is that the goal is to really provide safety in numbers for our participating hospitals. So we've heard a lot of kind of fear and confusion from hospitals and clinicians in terms of like how to navigate these laws, where to set the threshold for example, like what is a medical emergency? How sick does someone have to be? Really, there's no way for the law to clearly define that, and we as like hospitals and clinicians need to figure out where we're setting those thresholds. And there's a lot of safety in coming together and setting, between institutions, and having some consensus in how people at different institutions and hospitals are interpreting this, are providing care, and are documenting. And so that's also one of the goals is that safety and number piece across the state, and part of where I think both the protocols and the convenings can be useful. So just to go through some specifics of documentation in Iowa. So we have listed here some of the required additional pregnancy termination documentation. And so folks are required to fill out a statistical report of termination of pregnancy form. And there are details on what needs to be included. So the law says that providers need to make a good faith effort to obtain with each termination the healthcare tracking information, patient demographic information, and information about the patient's pregnancy and termination. Um, They say that this needs to be filed before the 10th day of each calendar month, and then also within 30 days of the date of the occurrence. And they do specify that the information will be collected, reproduced, released, disclosed in a manner that ensures the anonymity of the patient, the healthcare provider, and the hospital. I have a note here, like there are definitely legitimate concerns, right, about the degree of anonymity, that word, how anonymous this is going to be. And so a lot of our actual medical societies, the Guttmacher Institute, different groups, have really come out against this type of reporting and requirements for this type of reporting, because I do think there are very legitimate concerns that things can be traced to particular patients, for example. Um, but we do have many states where this is currently being required, even though, again, it is something that we are advocating against. And so I think just keeping that in mind as you are doing required reporting, how to make this as anonymous as possible within the requirements that exist. I think this is another piece where the safety in numbers does come into play, where again, if multiple institutions are interpreting and providing care in similar ways under standard protocols, I do think that is very protective in the setting as well of documentation requirements. And then there's also a requirement for fetal death certificates, and the law says that this should be filed within 3 days after delivery for any fetal death that occurs after 20 weeks gestational age or greater. And so just going into from there, some sample EHR language, I think it can be really helpful when navigating these laws to have some sample language that is provided to all clinicians that folks can use to have some level of that standardization. So for us in my practice in Georgia, like we all have these dot phrases that are in our Epic that we're able to use that I think does feel helpful and protective. And so, for example, for an intrauterine fetal demise, saying, commenting, this is the number of weeks, intrauterine fetal demise, pregnancy confirmed via ultrasound, no fetal cardiac activity was defined on ultrasound. For things like, for example, medically futile pregnancy, we really pull language directly from the law. So here again, you're commenting on the indication, so medically futile pregnancy, the estimated gestational age confirmed via ultrasound, whether or not fetal cardiac activity was detected, and then here, like in the reasonable medical judgment of the physician providing medical care to the patient, the fetus has a profound and irremediable congenital or chromosomal anomaly that is incompatible with sustaining life after birth. So really taking that language from the law and being very clear and putting that in your documentation can be very helpful. Same for medical emergency. So kind of we have those same elements here, but then pulling that language again directly from the law and having that listed here in your documentation. And then the other piece here is noting that any kind of like 24-hour period or state mandated consent can be waived in a medical emergency. Okay, perfect. And then again, similarly, and we'll have all of this in the protocol that we'll send out to you all. But we also have like some standard language here for rape and incest. So kind of for each of these indications, thinking about how you can have some of that standard documentation language in your charts that is protective as you're navigating providing care in these environments. Okay, perfect. So we next wanted to, I'll stop. Well, we'll go into cases. Do we want to do questions first or turn off recording? We'll pause there, stop the recording,